with us if you can watch this.
Yep.
For years, we have worn a lead apron, a lead barrier. And that apron, or that barrier that we wear, it covers from about the neck to the knees. The problem is, it doesn't cover the arms, it doesn't cover the lower part of the legs, but especially, there's no cover or protection for the face and the head. So I call this an incomplete barrier because after a number of years of working in the cardiac catheterization laboratory, you potentially face the consequences of radiation to the bone marrow, radiation to the head and to the neck, and this can have very, very serious consequences.
The patient is Mr. Bernard Schuler. We shall return to the specifics of his case after Dr. Edward B. Dietrich, Medical Director of the Arizona Heart Institute, introduces the surgical team at the St. Joseph's Hospital and Medical Center Operating Theater. Dr. Dietrich?
Good evening in the studio. Can you hear us all right?
Loud and clear.
Good. We'd like to take you on a quick tour of the operating room before we start the actual operation.
Probably after we talk about people like Michael DeBakey and Denton Cooley, the name Ted Dietrich comes up as far as American cardiac surgeons and innovative surgeons.
Ted was a pioneer in the surgical space and in the advancement of endovascular therapy. At a time when many surgeons felt that surgery was the gold standard and less invasive technologies were inferior and should not be deployed in patients, Ted adopted the exact opposite position and tried to bring that benefit to his patients.
Dr. Dietrich was fearless. He took patient care head on.
My motive was make it safer and make it simpler. And that is the real thing that led into the endovascular field, where you didn't have to make an incision, you didn't have blood loss, patients could be discharged sometimes the same day. But to do that, we had to have the same capability to image and take pictures in the operating room that they had in the catheterization laboratory. The only way to do that would be to have an angiogram, a dye test, on the operating table. I want to do coronary angiograms in the operating room. Never been done before. I walked in the emergency clinic. Here was a C-arm mounted from the ceiling in the University of Münster in Germany. He said, we have one under production and we're going to save it for you. And so we brought that to St. Joe Hospital. And that was the first one that was in the United States, actually the first one in the world, except for the one at Münster.
Dr. Dietrich was a cardiothoracic surgeon who was one of the first to actually get into the peripheral world of doing this. It was left to interventional radiologists and cardiologists.
Ted had an enormous interest in getting in cutting-edge technologies, and he was always at the forefront in the development of many things.
My whole mindset was, we're going to do the procedure, we're going to show people how to do the procedure, we're going to be the leaders in the world in the development of devices for the technologies that we want to conquer. And the last thing I was thinking about was, how much radiation am I exposing my body to? Yes, I put on the lead aprons they always brought them in, put them on us. Once in a while I'd put the lead around my neck, but I wasn't very religious about that. I tried for a while the lead glasses. They were too heavy and I didn't like them, so I gave that up. I think I felt this radiation cannot hurt me. It can't hurt me. I felt indestructible. Obviously, I didn't know what I was talking about, did I?
I think that his death brought a real awareness to all of those in the endovascular world about the risk of radiation exposure working in the cath lab.
It is a controversial subject, and not totally proven that people that have been exposed to X-rays or had developed brain cancer. It could have been coincidental, or it could have been a causative factor, but it's not totally accepted that that is the case.
There's no question the radiation protection was not the number one thing, in either design or implementation in terms of my own, experience working there. Whether there was any real cause and effect, which I know he definitely attributed it to that, that still remains, I think, uncertain in my own mind. The linear connection between radiation and cancer in any individual is very hard to, it's hard to know. I mean, there are other effects of radiation like cataracts, where there are very peculiar changes that occur in the posterior aspect of the lens that have been identified to be specific for radiation-induced cataracts in the posterior part of the lens. That's a little different than a straight line between one particular tumor. I have to say, I can't say with certainty.
It's just not known yet what the effects of radiation over a 10, 20, 30-year career is. This lead that we do wear doesn't block out 100%, right? It only blocks out 90%. So we're clearly, every case, getting significant radiation exposure. We're doing the experiment right now. I feel pretty confident that my patients are safe, right? We don't worry about patient radiation. Even the fellow or woman that's come back for multiple procedures, that risk to them is zero.
There's no doubt that we all have concerns in the back of our mind about what this low-level radiation does to us. So many of us know of colleagues that have had tumors, cancers, things that, who knows, they may have been due to the radiation. They seem to occur a little bit higher in physicians who were exposed to radiation constantly.
My name is Juan Bernal. I'm an interventional cardiologist in Birmingham, Alabama. I wanted to share with you guys the story of Dr. Arce Niegas, or Dr. Arce, as we all knew him. The story is very close to my heart, not only because he was a colleague, a partner, but also a mentor, and most importantly, a father-in-law. He was one of the greatest, human beings that I've met. As a family member, he truly showed us the value of unconditional love and support. And as a physician, he really was a role model for all of us as what true doctorship should be. He trained as a general cardiologist and subsequently as an electrophysiologist. He was in the lab, a lot of the time, doing very complex electrophysiology procedures that no one else wanted to do, and interventions, very complex interventions that were also, referred to him. We had many conversations about retirement, but his love and passion for this profession was, too strong, I think, for him to completely let it go. He was a big proponent of radiation safety in the cath lab, but he always had in his back of his mind a concern with his exposure to radiation. He was diagnosed in January 2020 with a brain tumor. And he passed away in April 2021. I think many from the professional level, they lost a friend. From the personal aspect, I think, seeing his grandchildren grow up.
cancer problem is real, and that 1 in 25 of us will probably die of a radiation-induced cancer, and that's a very high statistic.
I want you to think about why the left side of the body is so important. The way we stand and position ourselves in the cath lab, the radiation source is from our left.
You know, it's scary as heck when you think about the fact that when you look at interventional cardiologists with brain cancer, that over 8 out of 10 of those brain cancers are going to be on the left side. And so that's where we get radiated.
So we stand right next to the radiation emitter. And what I've noticed is that on my left leg here, I don't have any hair at all here on my.
It's just on the one side.
It's just on the one side, because that's where I'm standing, and the radiation affected it. So it's really strange.
My name is John Thomas Egan Jr. I'm trained as an interventional cardiologist. I've been practicing since 1993. It is estimated that I did over 30,000 coronary and peripheral procedures. More than half of those were interventional procedures. In the early years of cardiac catheterization intervention, we, the interventionists, were not as good at keeping up with our badges or minding how much radiation exposure we had. So my history of radiation exposure and my illness started around 2004. I had spent most of my career working at least 5 days every day in the cath lab, 10 to 15, sometimes 20 procedures a day. And in the early 2000s, around 2003, 2004, I began to develop multiple skin cancers, mostly on the left side of my body, in my left lower leg, my left forearm, my left hand, my left shoulder, my left cheek, my left temporal area, and my left neck. At the time, it was felt that these cancers were related to previous sun exposure. So I continued full-time work as an interventional cardiologist, spending 5 days in the lab, 10 to 20 procedures a day. Over the next year or two, I began to experience more cancers on a monthly basis, and then it began a weekly basis. And then ultimately, around 2008 and 2009, I was going to the dermatologist almost every day because a new lesion was breaking out on the left side of my body. At that time in 2009, it was determined by my doctors that I should step out of the cath lab, get no further radiation exposure. It was recommended at the time that my illness could be radiation related. I ultimately published my history in the Journal of Interventional Cardiology at the time, and it showed in that article that about 90 to 92% of all my skin cancers were on the left side of my body, and less than 7% were on the right, which pointed towards possible an exposure to the left side of my body. I suffered from over 100 skin cancers on the left side of my body, which finally had cleared up after 3 years. When I went back in the cath lab, I tried to utilize as much protection as possible, but sometimes it wasn't practical to use complete protection trying to take care of very sick, acutely ill cardiac patients. In around 2015, 2016, after 2.5 years back in the cath lab, I developed a recurrence of multiple skin cancers, all on the left side of my body. My left forearm, my left hand, the left side of my face, cheek, left shoulder, and left shin. Went back to my doctors at UAB, and they immediately recommended that I remove myself from any radiation exposure, that it had become cumulative and the effect were permanent, and that any more radiation exposure could be life-threatening. At this point in time, I've not had a cancer in about a year, which is great news, but I really attribute it to removing myself from all radiation exposure.
All of us have had personal experiences of mentors or colleagues that have been diagnosed with cancer at a young age, and we always keep wondering, was that really the effect of radiation, or is just some sporadic bad luck that has happened? But everything points to the logic conclusion that the more a physician is exposed, that is the end effect.
Well, I get very emotional, and if I do, I apologize, but this is very emotional to me because this is what I wanted to do. When I was at Emory, I knew that coronary intervention was going to be the wave of the future on how we took care of patients with coronary artery disease. So when I had to step away, it was extremely emotional. Over those next few years, getting treated for multiple recurrence of cancers, it became very difficult. I had to seek help from a psychiatrist. I didn't know if I could ever practice again. I worked very little, but fortunately, I was able to get better and was able to come back as a non-invasive cardiologist, and that's what I do today.
I would like to say we know everything there is about radiation exposure and the effects on human tissue, but I don't believe we know nearly enough. There are whole voids in pathology that we treat with radiation that we don't know the effects of it. So is it safe to have the fluoroscope on for 5 minutes for a neck operation? Maybe. Maybe 1 minute is too long. We don't know the answer to those.
So nice to meet you. I've heard so much about you.
Absolutely.
I'm a fan.
As physicians and scientists, we are really data-driven. We look at large trials to determine how we make decisions for our patients. But when it comes to radiation exposure in the occupational sense, we're really limited in the data that we're relying on. These are observations and extrapolations from Hiroshima, and that kind of data might not be as solid as we need to really understand what the true risk is to physicians and operators who are exposed to radiation on a daily basis. When I was initially interested in pursuing a career in interventional cardiology, radiation was really the last thing on my mind. I was passionate about the field, how rewarding it was, the ability to help patients. And it really only got to the point where I was about to start interventional cardiology fellowship, which is, after 11, 12 years of training after the undergraduate degree, that I realized that there was a lot of radiation exposure. And it just so happened that around the time that trainees get to that point where they're doing that training, they're in their mid-30s. I was around the same age, and I had kind of pushed off having kids for as long as I possibly could to make it through sort of the grueling medical training, but I wanted to have a family, and that is when I started thinking about the specific concerns of how to balance having kids and pursuing a career. So I did a national survey with the American College of Cardiology, asking almost 600 fellows in training why they were interested in going to interventional cardiology and what were the reasons that they might not want to. We found that men were much more likely to be interested in the field, but not for the reasons you would expect. Women were much more concerned about radiation exposure, particularly during childbearing years.
Well, I think that when my colleagues are pregnant, then it becomes a huge issue because we don't really know what is safe and how much is safe. And as I see my partners have 2 sets of lead on, trying to protect themselves and trying to shield themselves as best possible, I am concerned that they're putting their unborn child at risk.
Think about this. A physician may come into the operating room theater and do 2 or 3 procedures. And then the next physician comes in and he or she will do 2 or 3 procedures. So I may be in the lab a total of a couple hours a day, but our nursing staff and our x-ray techs, they are in the cardiac catheterization laboratory all day long with multiple physicians.
My name is Mackenzie Cruz. I graduated from X-ray school in 2018 and started in the cath lab when I was 19 years old. So I've been in the cardiac cath lab now for just over 6 years.
So you're leaving?
I am leaving. So like I said, I've been doing this for about 6 years now. I really love it. I love my job. I love medicine. But the most at-risk person when it comes to radiation are young females. Actually just got married this past August, and yeah, we're talking about kids, maybe 1 or 2. So yeah, that definitely makes me think of, am I gonna struggle to get pregnant because of what I've done for a career? Cancer runs in my family pretty prevalently, so did I just increase my risk of getting cancer? Who knows? There's no way to really prove it, but it's definitely something I think about.
My name is Amy Armstrong, and I'm a congenital interventionalist, which means that I treat congenital heart disease, which are heart diseases that children are born with. I got very little radiation training in my fellowship. In fact, I barely even remember receiving any. And I remember that the physicians who taught me didn't like to use the lead shields because they got in the way. So the lead that most people wear is 2-piece lead. We have a lead skirt that wraps around, and then we have a vest that either opens in the front or opens in the back. And you can have a gap in the armpit area where X-ray could be getting through to your breast. I was diagnosed with breast cancer in 2021, and this was a big shock because I don't have it in my family. I don't have any genetic predisposition. And it was in my left breast, which is the breast that is closest to the radiation when I work. And because I'd had a very recent normal mammogram and ultrasound, I did not think I was going to make it for more than a year. I was really worried about my family, how my family was going to go through all the important things in life without their mom or the wife. And I also was sad for myself that I was going to be missing so many things in their life. And I feel kind of selfish that that's what I thought, but I was feeling sorry for myself that I was going to miss out on so many fun things.
Take a fork and then mix that around. Mix that all around.
I think my cancer brought us all closer together. When you get cancer, you think about what really matters. And honestly, I didn't think about my job or my work when I was diagnosed. I just thought about my family. But my family was such an amazing support system for me, and it made us cherish the time together that we have. When do you start classes? Is it Wednesday
Part of the
mornings or
reason
class?
for wanting to avoid radiation is there's bad things that can happen from radiation. And one of them, and how it applies to what I do, is that they can lead, or at least a known factor in the development of some tumors is exposure to radiation. It's hard to pick it out before it happens. Is that going to happen to me directly? And so that's why we just try to avoid any exposure to it, because it's so hard to predict which of these things might be affected in me. I don't want any of it.
Not a whole lot of people have put this together, have made the contact between excessive radiation and tissue damage. For instance, I have no question in my mind that my carotid artery, which had a very, very dense calcific plaque, was related to excessive radiation. The radiation is coming right there, the scatter's coming right to my neck. I'm highly suspicious that that little 8-millimeter brain tumor, the oligodendroglioma, it's the same radiation exposure. I don't have the proof of the brain tumor. It's a hunch. Yeah. I'll bet I'm right. I'll bet I'm right.